We'd like to introduce today's speaker. Dr. Nicholas Tatonetti is Vice Chair of Operations in the Department of Computational Biomedicine and Associate Director of Computational Oncology at Cedars-Sinai Medical Center. He received his PhD from Stanford University, focusing on novel statistical and computational methods for observational data mining. For the past 14 years, he has applied these methods to drug safety surveillance, discovering and validating serious adverse drug effects, and drug-drug interactions. His lab at Cedars-Sinai uses large-scale clinical and molecular data to make robust scientific discovery, particularly in detecting and validating drug effects and interactions. Dr. Tatonetti has published over 130 peer-reviewed papers and is passionate about integrating real-world and high-dimensional biological data to advance the scientific method.
My goal is to use data, machine learning, AI techniques to try to remove the anxiety around taking medications. We all have experienced this or have taken care of relatives that have experienced really dire and adverse side effects from taking the things that are supposed to help us feel better. And that does not feel good, and it causes lots of anxiety. So if there's a way that we can use new methods and large data sets to understand drug effects and to get that information out there and to maybe better tailor the use of drugs for different patients and patient populations, then I'd like to be helping to make that happen. Adverse drug reactions are a major cause of morbidity and mortality. They cause up to 6% of hospitalizations in the US. They cost the healthcare system millions, billions of dollars annually. And in fact, 20% of people are taken off or voluntarily stop themselves a prescribed medication due to the side effects that they cause. This anxiety drives posts about medicine on social media, drives reports to the FDA about adverse events, and drives lawsuits as well. Underrepresented groups are especially disadvantaged when it comes to drug side effects. For example, women experience twice as many drug side effects as men do. In fact, this is a direct result of traditional clinical trial practices, which excluded women from clinical trials and treated them as a special subgroup, something that was only changed in 1993, relatively recently. Drugs that were approved before then, of which there are a lot, were never really studied in women until after that point. Adverse drug reactions account for up to 10% of pediatric hospitalizations. Children are another understudied group. Randomized clinical trials in children are really hard. First off, nobody really likes to put their kid in a randomized controlled trial. Nobody likes to experiment on children. So there's really good reasons why it's hard to do these studies in children, but it means that we know a lot less about how drugs work, and more importantly, how they don't work and cause potential harm in this population. In fact, I'm just going to kind of highlight this with this case study of a drug called montelukast. Now, this drug is really good at treating asthma, but it also caused some really significant side effects. So here's a post from someone who posted on the social media website Reddit that they were anxious about putting their daughter on this drug. A lot of kids take this drug. This parent is asking other parents if they have any experience about this. They've heard of these crazy things, these crazy side effects, and is very nervous about taking this next step and putting their child on this drug. And you can see some of the initial responses to this. You can see Clown Cowboy saying that that drug is the best thing that ever happened to them. And you can see that the poster is encouraged by that. You can also see some other people later on. I'm just kind of scrolling down a little bit so you can see some of this really long and detailed interaction between the different posters on the website. This person has a pretty measured approach, says that most people don't have side effects. You could have her try it. This person has been on it for 9 years and had great results. Like I said, when it works really well and people really like it. But then there are scary stories too. Not all of these posts were were telling her that everything was good. Here's somebody who had taken it 15 years ago when they were a kid and had really terrible nightmares. These are not your typical nightmares. These are things that keep kids up at night. They cause depression and other side effects. It can get pretty severe, and it affects children pretty significantly, but not all children have this effect. And as you can see, there's these really significant episodes in their lives, and taking this drug was not worth the risk. And in fact, they were on it for a really long time, experiencing these symptoms before they were realized. You can see the next person even pointing out that this drug has a black box warning. Now, just to make sure that not everyone feels anxiety while I'm giving the rest of the talk, this is the end of the story. So about a year after the original post was made, this user came back and did an update and said that their daughter has been on the drug for about 4 months with no side effects. So everything seems like it's going good for this parent and child, but that's not to say that these aren't potentially scary. More evidence. Now, in particular for this Montelukast story, the mechanism for this effect, which is very severe and very real, well documented, is currently unknown. We don't really know why this drug is causing these really horrific nightmares in a very small percentage of patients. And because we don't know and we don't have any risk factors, we can't predict which children are going to experience them and which ones are not. The question I want to answer is, can we produce high quality evidence from large data sets that we have access to without putting more children at risk? And I propose to do that by using medicine's so-called digital exhaust, all of the data that's generated by the practice of medicine. So electronic health records, which are widely adopted around the country now, capture the events of clinical care. Giving you a snapshot in time of the electronic health record data set here at Cedars-Sinai in LA. We have about 4.5 million patients represented in this data set. And those patients have been prescribed 76 million different drug prescriptions, have been diagnosed with 217 million different diseases or conditions, have undergone 88 million different procedures, and have had 450 million different laboratory tests, things like blood draws, glucose measurements, cholesterol, et cetera, done. And in fact, on top of all of that structured data, there's unstructured data, hundreds of millions of notes and reports that also exist for all of these patients. The average patient record has about 500,000 data points and consumes about 80 to 100 megabytes per year. This is one example of a data set, but in fact, aggregations of these data, this one being a Medicare claims data set, produces even larger databases that we have access to, at least in partial form, to do this type of observational research and perhaps learn about the effects of drugs. In this database, which is commercially available, has about 150 million patients and represents a lot of different procedures, diagnoses, and prescriptions. In addition to that, though, are new biobanks, which are also integrated with electronic health records. These biobanks, like the UK Biobank across the ocean, or the All of Us Biobank here in the United States, represent hundreds of thousands of patients who are genetically sequenced, have other molecular markers, omics markers performed, and are connected to electronic health records. And this is a relatively old snapshot. Now it's quite a bit higher than that. Should update that. But there's a problem with using observational clinical data like this. And it's represented by these redbirds and yellowbirds on this slide. So I'm going to invite you to imagine that you want to take a walk through the park I know that Seattle is really beautiful. You have lots of trees. So maybe you want to walk around or walk to your local city park. And you know that there's a lot of birds in that park. And so one day you're maybe gazing out the lab window and not really thinking about your laboratory work, but you're thinking about what is the relative populations of these birds that I often see on my walks through the city or through the park. So you decide to go out and make some observations. So you go out, you take a notebook and you walk around the park And you notice that you see, every time you see a red bird, you make a tick mark on the left. Every time you see a yellow bird, you make a tick mark on the right. And then when you bring it back to the lab, you analyze your observations, and you see that you observed 5 times as many red birds as yellow birds in your walk around the park. So what do these observations tell you about your very simple question, the relative populations of these 2 birds in the park? That's right, absolutely nothing. It's nothing because I'm going to tell you something else about these birds. See, redbirds, they love people. When they hear people walk in the park, they know they drop food, they know they can get a free lunch, and so they fly at them and they tweet at them and they try to steal all the food. But yellowbirds really don't like people. When they see people entering the park, they hide behind branches, they flutter and fly away. And so the behaviors of these birds has altered the very simple question that you asked of their relative populations, has altered the data that you collected so that you cannot answer that question. In fact, this is not just a hypothetical example of red cartoon birds and yellow cartoon birds, but this is actually happening in the clinic every day. The observations we make from the electronic health records are affected by the behaviors and decisions of clinicians, providers, and patients themselves. These behaviors often invalidate the data set for very seemingly simple questions that we could ask. So I'm going to talk a little bit more about how we might be able to use advances in artificial intelligence and machine learning to address some of these limitations. There's 2 stories I'm going to talk about today. One is in identifying sex differences in adverse events when usage patterns between sexes is biased. And the other is in boosting power in pediatric adverse event studies where sample size is either very low or non-existent. These are both situations that are typically difficult to address in using traditional biostatistical analysis. So let's type into the first one, looking at sex-linked adverse events. As we discussed at the top of the talk, women face a greater risk of adverse events than men. And we have, and then those events can be reported to the FDA, where we have developed an algorithm that takes data that's publicly available from the FDA, attempts to correct for sex-linked biases in terms of the prescription patterns of drugs, and identify adverse reactions or side effects that are specifically linked to sex. For this talk, I'm going to be using sex assigned at birth, biological sex assigned at birth. I use sex as a proxy for that, though this is because the FDA does not collect comprehensive data on gender identity. We're going to then analyze that data, identify these biases, integrate them with pharmacogenomic mechanisms to validate, and we produce this data set of sex risks at the end. So I'm going to talk a little bit about this. I don't need to go. I already went through each one of these, so we'll just skip through this. Okay. So in large, these sex differences are not known. There are a few cases, and you may have heard of some of them, but large scale on a population level, these are largely identified because of the historical biases against including women in clinical trials that existed before 1993. The data that we're going to use is from the FDA's Adverse Event Reporting System. This database, called FAERS for short, is an opportunity to systematically quantify sex-specific risks, but has many biases in them. There's differential prescription, meaning that women may take, people who identify biological sex, by biological sex, women might take more of a particular prescription than others, or vice versa, or the nature of disease or the drugs being used might be sex-linked. So breast cancer, for example, or prostate cancer. There also is sex-exclusive prescription. There is not yet oral contraceptives for males, and so hopefully that will change. And then age and co-medication can also influence and bias the observations. So the first thing we do is we measure these biases in this publicly available data set from the FDA, where we calculate what the association is between sex and drug prescription for all drugs. So for example, this is assumed to be sex assigned at birth, male or female. For each sex-specific adverse event, so these are adverse events that we have specifically associated with one of these sexes assigned at birth, like vaginal infection or ejaculation failure. And then we compute this statistics. I'll gloss over the statistics for now, but I'm happy to dive into them and answer questions later. We're just going to skip that. What we find is exactly what you'd expect, which are that drugs that cause side effects that are biologically connected to sex are much more likely to be prescribed or associated with one sex versus the other. So things like ejaculation failure, penile swelling, and testicular pain are all associated with males, and things like female infertility, uterine mass, and vaginal infection are all associated with females. So we're going to leverage machine learning to mitigate these biases, identify sex risks, and then compute a database. We're then going to use clinical literature and pharmacological knowledge, pharmacogenetic knowledge to validate these approaches and create a biological understanding for these differences. The method that we produce is called AWARE-DX to identify these sex-specific associated or sex-associated adverse reactions. What we do is we digest this patient data using any machine learning algorithm will do. We use random forest in this one. Some more modern techniques would also work pretty well. They work pretty similarly in our evaluation. What we do is we estimate what's called a propensity score. And this is propensity that a patient is either classified as female or male. And we use that as a way to control for male-specific or female-specific prescription patterns. So we repeat this many different times, and we learn these patterns of prescription, which allows us then to correct for those patterns of prescription and create more fair comparisons between groups. And so if the sex bias is the male association minus the female association, then you would compute it as the difference of the two, the absolute difference of the two. And so what we're showing here is that by applying AWARE-DX, you can actually mitigate this bias. So we've quantified the absolute bias in terms of the difference between the sex differences that we observed. And then what we did is we applied our AWARE-DX algorithm to see if those biases are reduced. And what we find is across the board reduction of those biases. In fact, almost 80% of the bias from sex-specific prescription patterns is removed from the association statistic by using our method. Then what we can do is apply this method systematically to identify new associated side effects that are sex-associated side effects. Let's get that. We then independently curated from the literature 22 expected sex differences in drug side effect pairs. And there was a few others that we ignored. And what we found was that our algorithm was very good at predicting which sex would experience the adverse reaction. You can see that here in just the contingency tables that we show and overall performance statistics. Then what we wanted to do is see if we could find a molecular basis for the observations, the sex-specific adverse event observations that we found. So what we see is that we might have expected differences, for example, in expression or of a particular gene or the activity of a gene that is associated either with women or men. And then we can use that to actually predict on a molecular basis which sex would be experiencing the side effect. So here's a concrete example. The gene ABCB1 is a transporter that pumps drugs across membranes. And it basically pumps the drug based on its affinity for the drug and helps with the excretion process. Well, variants in this gene can affect the activity of the protein and therefore will affect the availability or the elimination of the drug. So variants in this gene are associated with adverse drug reactions. So for example, this variants in this gene are associated with prolonged QT interval from this drug risperidone. And the reason is because women and independently, people who have a SNP or a single nucleotide polymorphism in this gene that contributes to lower expression, means that the drug will be at they'll be at higher risk of overdose for this drug, which will increase the risk of QT prolongation, which is a known effect of an overdose of this drug. And then analogously, for a different drug, same gene that's also transported by this ABCB1 gene, you expect the exact opposite effect, meaning that men would be at higher risk in this case. And statins are associated with myalgia, but we expect them to be associated more with men than with women based on this pharmacogenetics analysis. And that is exactly what AWARE-DX predicted. In fact, we curated 28 expected sex differences based on pharmacogenetics, and we evaluated AWARE-DX's ability to differentiate them. And again, it did quite well in this analysis based on the statistics. So overall, this approach, and a shout out to Payal, who led this study in my group. So there's relatively low recall, which could be to the requirements that we made of the algorithm to make sure that we had a lot of data. There's a lot of drugs that don't qualify or pass, and so that means we miss a lot of them. It is important to note that we didn't have any false positives during our validation phase. It's really encouraging, but there is no gold standard for validating this type of thing because there hasn't been these types of data sets generated before. There's no way to show that we're right definitively other than looking at these other proxies like literature data or the molecular mechanisms. With that, we'll take a look at our second part of this story, where we want to boost the power in pediatric adverse event studies where the sample size is very low or non-existent. If we recall, I mentioned that the drugs that, or it's very difficult to do trials in children for very reasonable reasons, but we would like to try to address that limitation by using machine learning algorithms. Child development is really important for care and treatment. So pediatricians, for example, tailor the regimens that they prescribe to their kids based on the stage of development. The physical, mental, and emotional milestones can influence the care that a pediatric patient is given, and developmental milestones reflect pediatric biology, also called ontogeny. This dynamic biology during childhood can greatly affect the action of drugs that are taken in different development stages. So children are not one group, but as a child develops and moves through the different developmental stages, the response to a particular drug or the child's ability to metabolize that drug can change drastically. So for example, enzymes that metabolize drugs, also commonly known as cytochrome P450s, are shown here in this top right graph. And you can see, you don't have to know exactly what's in the graph, but the fact that the lines go all kinds of up and all kinds of down, this indicates the dynamics of that enzymatic activity over childhood. These dynamics can greatly affect drug outcomes. So one example is valproic acid and liver failure. Valproic acid is an anti-seizure medication that is commonly used in children. And the metabolism of valproic acid, the expected metabolism, is critical for its function and safety. Large changes in metabolism do depend on age, and increased metabolism at a young age results in an increase in liver toxicity, a buildup of this drug in the liver that causes toxic effects. Pediatric guidelines do exist, but they're very limited. They're based on case reports or maybe a few very small clinical trials. The evidence is weak and anecdotal, and they don't cover all drugs or all adverse events. So we built a data-driven approach to derive observational and mechanistic insight on side effects that affect kids. Our strategy considers observations from across all development stages and is connected to biology so that we can try to come up with good molecular hypotheses about what we're observing. And then we evaluate the observed drug risks with some mechanistic data. Ultimately, we produce a data set, which we call KidSides, which is the first comprehensive database of drug safety predictions in children. Again, we use the FDA's adverse event reporting system, and specifically, we use about 270,000 reports for children, and children are defined up to 21 years of age. We find that a lot of stages are missing. So considering a single drug, maybe like montelukast that we started talking about at the beginning, there are some stages which are not represented. So in fact, 91% of adverse reactions have at least one stage that's missing from the data. So as we expect, because data from children are relatively sparse compared to data from adults, there's a lot of missing data in the FDA's adverse event reporting system. So what we do is we have a strategy of borrowing information that can infer when no data are present. And the way that we do this is we share reporting information across different stages. The central hypothesis here is relatively simple. It's that, excuse me, the metabolism or the biological processes of development will be more similar amongst adjacent stages. So we share information amongst adjacent stages to infer the effects in between. These models, which are called generalized additive models, have been used historically for different types of purposes, never for drug safety analysis, but for other types of studies like environmental studies with great success. We introduced the concept of a DGAM, or a generalized additive model that is built specifically to infer developmental stages, drug safety signals for developmental stages. Here are some advantages of using our methodological approach compared to some others. So one strategy could be to use the age directly in a linear model. Now, that's powerful when the model assumptions are met. So if the risk of a drug effect increases linear with age, or increases logarithmically or exponentially with age, or whatever your model might be with age, then the model can be very powerful, and it's probably the best thing to do. However, when it does not ascribe to those assumptions, which is pretty common, then you'll produce a lot of false positives, and you may overfit your data. So in that case, it's not that good of a model choice when you don't know already a priori what the expected response is going to be. You could model each stage independently, and that has the advantage of making no model assumptions, but it's also pretty weak in terms of statistical power. Modeling with GAMs is a little bit of a in-between, where you get some extra power by making some modeling assumptions, basically that adjacent stages will be more similar to each other, but you get a lot of power from doing that. Here are some plots to show that using this approach enables detection of side effects in very low data situations. So these are situations where we reduce the number of event reports down to just a few, or in fact, none. And we show that our method, which is shown in red, performs pretty well. The performance is robust to this missingness, whereas the traditional method shown in blue is quite sensitive. DGAMs also improve the detection of known ADEs. Montelukast, which is the example we started with at the beginning, is known to cause paranoia. And in a traditional method, in the toddler stage or in the neonatal stage, you would never be able to estimate these. But patients even as young as toddlers are put on these drugs. And so we wouldn't be able to, using a traditional approach shown in blue, to estimate what the risk was. But using our approach, you can get an estimate of that risk. In fact, we then apply these DGAMs after we've validated them to evaluate 500,000 different pediatric adverse drug events and group them by the stage that they were associated with. So you can see a lot of effects. The neonatal stage in infancy and gradually decreases. The effects that we find actually reflect known developmental biology. So here are some specific examples. So adverse events related to congenital diseases or family and genetic disorders are clustered in neonates, as expected. Adverse events of the endocrine system are clustered during adolescence, again, which would be expected when that system is being developed and undergoing significant changes. Immune system is adverse events of the immune system are clustered in the infancy and toddler phase, exactly when the immune system is kicking off. So we can see the relationship between dynamic developmental biology and the adverse events that we're observing in the adverse event reporting system. We had several different patterns that we were able to identify of adverse drug events in children, some which were very low risk for infants, high risk for adolescents, and then low risk again as children become adults. That we call plateau. There were some that just increased over time. There's this inverse plateau, which was relatively rare, where we saw that the risk of adverse events was high in both neonates and in late adolescence, but not in the middle stages, and then a decrease over time. You can see that most common was a plateau. So most common was that there was one stage that was likely driving the signal, and there was probably a developmental biology reason why that adverse event was coming up. In fact, using these data, we can start to figure out what the mechanism might be of these adverse drug events. So in fact, if we observe the expression of a particular enzyme decrease over childhood development, but we see the risk increase, then we can infer a certain type of metabolism, that the drug itself and not its metabolites are increasing the risk of the adverse reaction. However, if we see that they're consistent with each other, both the expression of the enzyme that metabolizes the drug and the risk decrease over childhood development, then we can infer that the metabolite is actually the causative agent of the adverse reaction. These are just some examples that we were able to decipher, where we show that you can identify whether or not it's the metabolite or the drug itself that is potentially responsible for the adverse drug reaction. So we actually use this approach to go back to that question about Montelukast. And Montelukast, where we don't know the mechanism of action. Montelukast is a leukotriene receptor antagonist and a 5-lipoxygenase antagonist. These are two possible ways by which Montelukast is potentially causing these severe neurological conditions. So what we did to evaluate these hypotheses was to compare Montelukast to other leukotriene receptor antagonists. And we found that while Montelukast was significantly associated with many different significant psychiatric ADEs, that our comparator drug, which was also one of these antagonists, was only associated with one of them. Whereas for these ALOX5 antagonists, we found that all three drugs shared significant associations to pediatric psychiatric ADEs. This resulted in a hypothesis that ALOX5 and not the leukotriene receptor is in the pathway for causing these effects, opening up some potential new research. So these DGAMs are statistically more powerful by sharing data across different developmental stages, but they do make some assumptions and so have some limitations there. And we created an integrated methodology that combines biologically inspired modeling from developmental stages with our observations of adverse drug events in the adverse event reporting system. And we can then use this to identify new adverse drug events, where we produce a database called KidSides, which is freely available for anyone to evaluate and analyze for research purposes. And we can also shed some light on some potential biological mechanisms that might be underlying some of these differences that we observe. With that, I'd like to thank you for your attention and your time today, and I'm happy to ask questions.